You're listening to the Good Question Podcast with Richard Jacobs. Our goal is to make each of our guests exclaim, that's a good question. I don't know the answer. Because when that happens, it means you, the listener, may be inspired to learn more beyond the interview and to ask great questions yourself that lead to new insights. In this podcast, we cover historical and current anthropology, comparative religion, and history. Welcome, and let's get started.
Hello, this is Richard Jacobs with the Good Question Podcast. My guest today is Nicholas Young, PhD. He's with More Than More's Precision Medicine Solutions, MTM. He's a research scientist and CEO. Today we're going to talk about lupus and perhaps some other autoimmune diseases. So welcome, Nicholas. Thanks for coming.
Thank you for having me, Richard.
Yeah, let's start with your background. How did you get into the investigation of lupus? What did you do before this?
That's a good question. So I did all of my education, the beginning of my training was at Ohio State University. I had an undergrad in microbiology and biochemistry, which, wasn't necessarily lupus focused at all. I ended up doing cancer research in graduate school and really got a lot of training in immunology. And the rest of my career from that point forward leveraged the background in immunology. So I've done work in infectious disease, rheumatology, and oncology with that focus. And the work in lupus specifically was done the Department of Rheumatology and Immunology at Ohio State University, Wexner.
Okay. And in the beginning, I know it was important for you to give the caveat that, anything you're going to discuss here on the podcast is more based on your own experience and your own opinion, and it's not necessarily associated with any of the places you worked or work at right now, right?
Yes, that's absolutely correct. I want to have the opportunity to speak freely and at the same time make sure that everybody is aware that I'm expressing my feelings, my opinions, my understanding of the direction field, and not just that.
Okay, well, fair enough. Well, let's talk a bit about lupus. So for the layperson, what is lupus, and what are the symptoms, et cetera? Then we'll dive into it.
So lupus falls under a category of autoimmune diseases. It's rheumatoid arthritis is another common autoimmune. In all of these autoimmune diseases, something happens. There's a dysregulated immune system. The immune system responds to self-targets, reacting to the person's tissue. There's inflammation associated in different targets depending on what the autoimmune disease is. Lupus specifically, you see clinical manifestations primarily in skin, kidney. You get a rash, arthritic type joint. Lupus nephritis is severe disease that associate kidney. Again, all of these autoimmunes are something that's dysregulating the system to have it respond to self-target, and really just a very active inflammatory risk depending on the particular autoimmune have different targets. And all of the pharmacological treatments, as you would imagine, are trying to suppress that inflammatory risk. So the research that I did in the field of rheumatology was twofold. Some work we did was more conventional in just trying to understand these inflammatory pathways and then design targeted therapeutics to suppress that inflammatory response. And another part of the research that we did was looking at how complementary alternative strategies such as diet. So we did some work with curcumin, with a bioactive derivative of turmeric, that was formulated in the Department of Pharmacology at Ohio State, and looked at that and suppressing, and then also looked at exercise and exercise's role mediating inflammatory response, and meditative ways. The way that we characterized it was
like how meditation can affect outcomes with lupus, people that have it.
Yes, so it's psychosocial stress induction is what promotes an inflammatory response. So anything that would be psychologically suppressing that, a meditative type strategy to suppress.
Wait, are you saying that people that have autoimmune conditions, their mood and their emotional state is highly correlative with like a flare-up of their condition? Is that what you're saying?
Well, so what I would say is there aren't studies to demonstrate definitively that there's a direct correlation between those. However, what we do know from a fundamental understanding of the immune system is that you can dramatically affect immune responses with these alternative strategies like psychosocial stress reduction and exercise. So there are and even dietary things. There are ways by which you can suppress the inflammatory response. Is that ultimately to be a standalone therapy for a severe clinical manifestation of lupus? Probably not. But I do think that there is a place for those strategies in conjunction with traditional ecological.
Sure. Okay. Why? I don't know if this is true at all, but autoimmune conditions, they're called autoimmune conditions, but it seems like there's a preferential attack, an autoimmune attack that is limited. It's not like a full-blown response to the whole body is attacking itself. Maybe I'm wrong. But it seems like these different autoimmune conditions, they seem to, the immune system is compromised along a certain vein or in a certain way or for certain organs or certain systems. It doesn't seem to be like a systemic attack. It seems to be more focused. Is that the case?
Yeah, that is. Depending on the autoimmune condition, you'll have more typical organs of manifestations of different specific areas that the immune is attacking, which leads to different symptoms with different autoimmune. Could be inflammation in the muscle tissue, myositis, inflammation, moisture-producing glands of Sjogren's syndrome, so tear gland and salivary gland, lupus, like I said, skin and kidney, rheumatoid arthritis. The list goes on and on. That's a good point. There are conditions by which there can be more comprehensive inflammatory response systemically, but by and large, a lot of these autoimmunes are characterized by more targeted. Really, that's what distinguishes what that specific dysfunction is that leads to.
Yeah, but why would that happen? Why would there be a preferential problem with the immune system, and why wouldn't it just be an overall immune response? Like, what do you think that is?
That's a good question too. So, in the case of lupus specifically, there are a variety of factors that contribute to the development of lupus, and you really can have heterogeneous manifestations of the, had mentioned, target organs, skin. There are patients that don't develop lupus nephritis and have less severe. Why exactly certain organs are targeted and certain organs spared is not as well understood, and it's part of what is active research in the field. What is more understood is are the fundamental pathways that are being stimulated different. Sometimes it's similar in the pathway that's stimulated, and it really, over the course of my career, there have been a lot of different therapeutics that have been developed that are targeting these pathways where historically they were giving non-specific, but it's that a steroid, a sledgehammer that shuts down all, and now they're more targeted. So I think, to answer your question, you do see an overlap of some of these targeted therapies given from autoimmune condition, but the underlying etiology of why the immune system is attacking certain organs and autoimmune, I think, is less.
All right. So, again, for lupus, how does it start? Is it primarily in men or women? Like, how do people first find out that they have the problem?
Yeah, no, those are all good questions. So like I had mentioned, it's a heterogeneous disease, so it can manifest differently. And really, I think that that's largely contributed to the fact that it can have a lot of different. So there is a genetic correlation with lupus. However, when they've done studies with identical twins, if it was a 100% genetic association, then if one identical twin has lupus, then the other identical twin should develop lupus, but that's not necessarily the case. It's more like half and half. So there's a genetic correlation. Even seeing 50% is enough to say that there's a strong genetic correlation, but the fact that 50% still don't means that there are other factors at play, which could be environmentally influenced, or different immunological factors, say that it could be stimulated from infection or some other challenge that the immune has where it becomes dysregulated from that response. But one of the most interesting and where there is the strongest amount of data is the hormonal, in which you had mentioned as well. And with lupus specifically, what you see is a very, very strong correlation between lupus and physiological levels of estrogen. So when physiological levels of estrogen are the highest, so post-adolescence, premenopausal women, the ratio of female to male patients with lupus is 10 to 1. When you look at a postmenopausal physiological levels of estrogen drop back down, it's something like 3 to 2%. It basically goes almost back to 1. So you have a 10 to 1 ratio that drops significantly down. So there's a strong correlation between estrogen and the lupus patients in general, where it tracks with physiological levels of estrogen. That's always been known. And what a lot of the research that I did, what we tried to do was characterize why that potentially could happen. What influence does estrogen have over the immune system that could contribute to a dysregulation that could manifest? And it was really interesting to me when I first started to examine these questions that when you look across species, so in a variety of different species, humans all the way to much less complex organisms, what you see is females have a longer lifespan than males and are more resistant to infection male. So you say right there's a correlation between estrogen levels and the ability of the immune system to respond to being challenged by an infection.
What about people that are, they do BHRT, the bioidentical hormone replacement? Let's say they're in menopause or perimenopause. Does lupus,
yes,
do they have an instance of it sometimes when they do that?
Yes, you can see higher levels of patients with estrogen.
Oh, that can bring it out?
Yes.
Okay.
So, so it really, it tracks well with that. And like I was saying, if you say in general, across species, you see more longer lifespans and resistant infection and disease in females. It indicates that estrogen, while it could lead to a heightened immune system, which is great in the defense against infectious disease, it could also allow there to be, a situation where you tip the scales and the immune system becomes dysregulated. And if that happens, then you're at greater risk of developing an autoimmune disease like lupus. So that was really, one of the first areas that I looked into when I really started to examine, just study lupus on a fundamental molecular level, looking at potential pathogenesis of the disease, which if you could identify, then you can really try to develop a therapeutic that's targeting that. What we were able to do was show that if you just took white blood cells, so if I took a collection of white blood cells from healthy male individuals and healthy female individuals and isolated white blood cells, cultured them in a dish in the laboratory, at that point, the white blood cells don't know if they're male or female. They're just white blood cells in a dish. And you expose those, what we did was expose those white blood cells to the antigens that are in the Tdap vaccine. So diphtheria and pertussis. Tetanus. Yes, you're right.
Yep.
Diphtheria, pertussis, and tetanus. So we expose the white blood cells in addition to those antigens. Obviously, there's an immune response that you can measure in growth of the cells because the cells think that there's an active infection. If you do that in combination with estrogen, you get a heightened immune response in both, but that heightened immune response is greater in female cells. So it indicates two things. It indicates that estrogen itself can help heighten an immune response, and female white blood cells are wired differently to respond to that estrogen that's in the environment. So it's really suggestive that estrogen plays a large role in the inflammatory response in general. And since it does, it could potentially lead to an area where you're creating a dysregulated immune system and developing an autoimmune like.
And when you say estrogen, estrone, estriol, which form of estrogen seems to be the predominant cause of problems with lupus, or is it all of them?
Yes. So, in a physiological environment, they'll be metabolized in a way that they can stimulate the growth of cells. But we use estradiol when we're stimulating the cells in a dish. So that's the bioactive form for white blood cells.
Yeah, but when people do hormone replacement, they may need more estrone, they may need more estriol. It just depends. There's different kinds of estrogen, from what I understand. Is that being studied, or it's just estrogen is being looked at?
To my understanding, maybe in the field of hormone replacement therapy in general, there's a concern for if you're trying to treat a certain condition in that respect. But in the field of lupus and looking at how estrogen is involved in gene regulation, you're assuming that if you're applying estradiol or any form of estrogen, that you're recreating physiologically what's happened with levels of estrogen.
Okay. So what are the different manifestations of lupus? You said one is more kidney focused, one is not. What do the different types of lupus look like symptomologically?
So, like I said, you can really, the most critical, I guess the two most critical distinctions in a lupus patient population be whether the patient has lupus nephritis, so kidney involvement, or neurological related. And so those are the most serious clinical manifestation. Outside of that, the rashes, skin and joint and arthritis.
What age does this tend to onset in women?
Typically, it's older. The younger that you see patients diagnosed, the more severe the condition. So if you do see pediatric lupus, you see less so, but you do see patients in their 20s, early 30s. Those are the ones that usually are the more severe.
Okay, what seems to bring it on?
That's a good question too. So it's really unknown why disease wasn't there, then all of a sudden was there. What is the impetus to driving that inflammatory response? But estrogen could be something that is involved in that process. What you do see too is you can have a patient that receives treatment, goes into a remission, so very, very, very low disease state, and then has infection that's unrelated to lupus, just a cold or COVID or whatever it is, and you spark a flare of lupus. So there are a lot of different factors that could lead to either the beginning of the disease happening or a flare of the but at the end of the day, it's really all something that is stimulating the immune system, and that response then goes out of control and becomes pathologic.
Well, again, what is the symptomatology of a lupus flare-up typically?
So again, it would depend on the patient, and really it's a inflammation into areas where inflammation has been obviously. So if it is a patient with arthritis, then it would seem a rash.
Why do these old inflammation sites seem to be the preferential sites for the inflammation to recur at? What do you think is left that is signaling the inflammation to begin there again? Or maybe it was never healed in the first place somehow. There's some low level chronic underlying inflammation at these sites that never leaves but gets activated.
Yeah, no, I think what you said at the end there is exactly what it is. So I always characterize it as embers of a fire, where you're never actually completely extinguishing that fire, but you do have it's a chronic disease. There's chronic inflammation, but even at times where you don't observe clinical disease, you still have that very low level of chronic. Something happens, sparks that, and that's where it will flare. But I think really in a scenario where you always have some low level underlying disease there.
Good. So what are the current treatments for lupus? Like you said, steroids, injections at certain sites. Like what is the protocol?
Yeah, so they do. When I started doing lupus research, this was like 20 years ago, there was one treatment that was approved in the past 50 years, but we're at now 3 treatments specifically approved for lupus in the past 60 years. This, it indicates that we're making progress in the sense that there were 2 new things, but I think it really shows how much room there is for therapeutic development in this area. So a lot of the treatment strategies that were approved and used for many, many years, like hydroxychloroquine was used since World War II times, and Cellcept, another non-specific inflammatory agent, and steroids have been around for a long time. These new agents are targeted therapies, which are blocking specific signaling pathways within that larger network of signaling of immune system cells. So it indicates that there has been progress that has been made, but again, I think there are a lot of novel targets that still need to be developed. A part of the work that we were doing in research in that area had identified a novel signaling pathway that we did develop an antagonist for, and were able to demonstrate in a mouse model of lupus. So this was a humanized mouse model where we're taking the white blood cells, so the dysfunctional immune system from lupus patients, and engrafting it into an immunodeficient mouse. So you're just using the mouse as a vessel to grow the inflammatory disease in. And we're able to demonstrate that when we did that and used our antagonist, we suppressed the inflammatory response. So it indicates to me that there are a lot of opportunities available for therapeutic development. Unfortunately, I think there isn't that much focus around estrogen and estrogen's driving of inflammation, inflammatory disease, and autoimmune disease like lupus, the pathway that we identified specifically showed that estrogen upregulation, a receptor that's on the surface of certain immune cells, estrogen can upregulate the expression of that receptor. And if you block the ligand, so the molecule that signals through that receptor, that's where we saw that suppression of pathological inflammation in the mice.
With women that are still having that cycle, when does lupus flare-ups happen? Any part of the cycle preferentially? And, what other hormones are present in large amounts at those times that may correlate with what's going on?
That's an interesting question. I'm not sure whether that's been looked at in terms of stages of the menstrual cycle to say at higher levels of estrogen, does that correlate with a greater likelihood of there being a flare in a population of lupus patients? I don't know that, but what I do know is during pregnancy, so say there's a lupus patient that would really all lupus patients in general, if a lupus patient is pregnant, there's a significantly increased risk of recurrence of or flares of lupus or more active disease. So at a time where there's a consistently higher level of estrogen, it may just be a scenario like we were discussing before, where if that cycle is going up and down in 30 days, it might equal a homeostasis of an average level, but 9 months, during pregnancy, very, very elevated levels of estrogen, then there's a definite correlation with exacerbation of disease.
You mean when someone's pregnant, lupus manifests more strongly and more severely? Okay, interesting. When someone's treated for lupus, what do they experience? Does it kind of go away and go latent or quiet for a long time?
It depends on the patient. There are times when you could treat to remission and then slowly remove all medication. There are times when you need to be continually treated, but disease is under control. And there are times when you'll have relapse remitting disease or even refractory disease that isn't responsive to different therapies. So all of those scenarios exist. And I think it really just highlights that we need to do a better job subtyping these patients to be able to predict who's going to respond to what treatment and be able to predict the responders from non-responders, or even have a way by which you can use biomarkers to predict disease relapse or disease flare before you actually clinically see a flare. A huge area of research, the second part of what I said with evaluation of biomarkers for prediction of disease flare, one of, in my opinion, the greater deficiencies in the field of rheumatology is the focus on precision medicine and using precision medicine to guide therapeutic decisions. In the clinic, in rheumatology in general, it is more of a scenario where it's a subjective diagnosis of counting number of joints that are flared or whatever, looking at different blood biomarkers and checking 7 out of 12 boxes, and it correlates with a certain diagnosis. So it is somewhat subjective in that sense. And after the diagnosis is completed, they use a recommended treatment strategy. So it's not guided by a specific predictive test that would indicate whether a patient would be a responder or a non-responder. I know, just comparatively speaking, in the field of oncology, that's all that's done. Precision oncology now is taking over that field, and the way by which patients are, nowadays you don't have colon cancer. You have colon cancer that's microsatellite stable, that has a tumor mutational burden at a certain level, that's PD-L1 positive or PD-L1 negative. And all of these things can help determine what therapeutic strategies to use for what patient, even with the same diagnosis. So, two colon cancer patients don't get the same treatment because of that molecular profiling that's done at the beginning to determine what the treatment strategy should be. In the field of rheumatology, you don't see that yet. And I say yet because there recently was one test in rheumatoid arthritis that was just clinically approved, where they're able to distinguish population of patients that would be responders from non-responders based on a panel of biomarkers that they get from doing a blood sample. So just looking at white blood cell levels of expression of different genes. And I think that's really where rheumatology needs to go as a field in terms of being able to characterize these patients better at diagnosis to be able to determine which treatments to use, because you really are just cycling through different treatments and seeing what works and what doesn't work.
Yeah. Okay. Are there any unusual manifestations of lupus in certain populations, in men or in, younger people, or again, the nephritis heavy type of lupus?
So you do see greater predisposition to lupus in certain populations of patients. So females, obviously, like I had said, but Asians and African Americans too, there's a higher incidence of lupus. Why that is also unknown at this time to say what genetic background. Are there certain genes that are involved in making different populations of patients, different populations of people more susceptible to developing disease.
Other autoimmune conditions that tend to accompany lupus when it manifests?
A lot of the times you'll get this blanket diagnosis, and if you have joint involvement, it could be rheumatoid arthritis technically, but it still falls under the umbrella of it being lupus. So I think there are different autoimmune conditions that could go along with a lupus diagnosis, but it all also can fall under the greater umbrella of a lupus diagnosis anyway. One thing that I wanted to talk about too, we had talked about the pharmacological treatment strategies and what to do. I wanted also to talk a little bit about the research that we did with exercise and psychological stress reduction. I think that part of the work that I did going into it, I have a background in drug design and development. I was less excited about this work. In the outcome of this work, it really, really demonstrated to me how these non-pharmacological interventions could significantly impact the pathology of the disease. So we started all of this work. We had a lupus mouse model, and in our lupus mouse model, we had 3 different arms of the study. So these mice, just because of genetic predisposition, naturally develop lupus nephritis. So you could see in the kidneys the inflammation that develops in the kidneys, and you see it. It's called blood urea nitrogen levels in their urine. So you're able to track disease just through levels of these markers in the urine. And then when you look at the kidneys themselves, you see inflammation. So what we did was take that mouse model. We either did nothing, and that was our control, or we exercised the mice. And we exercised the mice, not rigorous exercise, but mice on a treadmill. We had to train the mice to be able to walk on the treadmill and, follow our directions. So they would do treadmill walking. That was the equivalent of a fast walk, of a human fast walk, not sprinting, not even jogging, just a fast walk for 45 minutes every day, 7 days a week. And the other group of mice was exposed to a protocol that was severe psychosocial stress, where they had an aggressor mouse that was introduced to the cage that really induced a psychological stress response in these mice that was able to be measured as, a significant psychological stress to the mice. So the mice that had the psychosocial stress induction had more severe disease happen, and the mice that exercised had less severe disease that happened compared to the control that we didn't do anything to. So, I called this our research because I said, of course, exercise is better and psychosocial stress is worse. But when you looked at it at a molecular level and you're looking at inflammation into the kidneys, it was really remarkable how doing nothing other than very moderate exercise, just walking 45 minutes a day, or having severe psychosocial stress induction can have this dramatic impact on disease pathology.
How does it change kidney function to have these stresses in the first place?
So, ultimately, it leads to kidney failure and heart failure. So that inflammatory response in these mice is fatal. So it would be like a patient with lupus nephritis that you've never treated with anything. So what we were doing was using that model and seeing different trajectories of disease with either exercise or psychosocial stress induction. And I presented this work, the mouse model part of it, and when I was presenting it after I was done, a woman came up to me, and she was a Tai Chi instructor, and she said, Tai Chi is moderate exercise and has a meditative component to it. You should consider doing that with your lupus patients. It was the exact, it brought all of that together. It was psychosocial stress, psychological stress reduction with the meditative component, and moderate exercise, and that there are some movements associated with it. So I was able to get a small amount of money from the Center of Integrative Health and Wellness at Ohio State to run a pilot study in our lupus patient population. So they had 3 times a week at the Tai Chi studio, they did a Tai Chi program there. And then they also were taught what to do at home and did that every single day. So they did 45 minutes to an hour of Tai Chi 7 days a week. We had Fitbits that they had so we could track that they were doing their exercise routine. And the neat thing about these Fitbits and all of these health trackers now is you get a lot of additional information too. So we could look at activity levels in general. We could look at sleeping and how everybody's, their sleep patterns. And what we were able to show, and then we also did regular blood draws where we looked at inflammatory biomarkers. What we were able to show is in this population of lupus patients that were receiving the same therapy that nothing changed pharmacologically. They stayed on the same therapy. The only thing that we're doing differently is introducing this Tai Chi routine. And in a short amount of time, so in a 3-month period of time, and we did regular blood draws, you saw a significant decrease in a lot of pro-inflammatory cytokines. And when you looked at the activity trackers, their activity levels were up, their sleep was longer, so probably longer and more productive sleep. And they all just, anecdotally speaking to them, all felt better, felt happier, you could see you're making an impact on their specific case just by this Tai Chi program. So it really was interesting to do. We didn't have enough time, I think, in that study to follow patients to say we could make a significant clinical impact because, over just a 3-month, 6-month period of time, you're not going to really have a dramatic impact in a patient that's had lupus for 20 years. What we were able to show is even in that short amount of time, you're decreasing inflammatory biomarkers, you're changing sleep patterns, you're making them feel better. If they would continue to do that, there's no reason to think that they wouldn't significantly improve clinically too.
No, that makes sense. That makes a lot of sense. So what's the future of treatment for lupus? What does it look like? Is it going to be one of these alternative therapies? Is the traditional allopathic medicine just not really making much headway? I mean, what do you see?
What I think is, to be honest, I don't think that there will be a lot of focus on the exercise component to it and the meditative component to it. However, I do think that there's really a strong place for that to be emphasized more to patients. And I understand in the clinic, physicians are overwhelmed with treating large numbers of patients and are very hyper-focused on clinical condition. If there's a way by which this information could be communicated more through a wellness component of a major academic medical institution where they could get these patients onto these programs or share that information with them, I think that would be really helpful. Pharmacologically, like I had said, there have been some incremental advances recently, hopefully, and where I think the field will go is more a precision medicine approach where you're able to stratify patients at diagnosis by looking at different biomarkers. Based on that data, you can pick either approved medicines for lupus or potentially off-label medications. So there are a lot of different biologics that target autoimmune disease but may not necessarily be approved for lupus.
Since kidneys are affected, what about biomarkers in urine? Seems like that's a pretty accessible and sensible thing to look for.
Yeah, we did a lot of work looking at biomarkers in urine. Unfortunately, there isn't anything. There are conventional biomarkers, kidney biomarkers, say whether there's decreased kidney function, but there aren't biomarkers that are predictive of therapeutic response.
Yeah, like what's showing up in the urine while they're having a lupus flare-up.
Yeah, we did. We had amazing collection of samples that included patients that had disease remission and then another time point where there was a flare and then a subsequent time point post-flare and post that treatment where disease went down. Perfect collection of samples to identify where you control everybody to themselves because you have baselines around it. And we weren't able to identify a biomarker that correlated with flare in the urine. So that's not to say that there isn't. It's just we weren't able to find anything. But I agree, that's a very logical place to look for those biomarkers.
Well, it's not really being looked at.
I think it has been. We looked at it too. There just hasn't been anything fruitful that's come out of that research yet. There may be more value. Those biomarkers may be effective in predicting a flare before a flare happens, where I think there could be more value in looking at biomarkers in the blood would be interrogation of white blood cell populations, where you could identify more what that dysfunction is, and then based on what you see in that individual patient, you could predict what therapy to match them with. So being able to predict responders from non-responders, that you would need the white blood cells from the blood to do.
Well, I mean, look, if they're attacking the kidneys, you would see leakage of proteins and all kinds of stuff, just like you see as a lot of people get older and their kidneys get weaker. I mean, you'd see a lot of leakage into the urine of all kinds of substances. So that's why I think it'd be a great catch-all to see multiple biomarkers of what's going on.
You do see more protein, and that's not to say you don't see lymphocytes also, but, it's nothing like a blood sample. They're chock full of white blood cells.
Okay. So very good. What's the best place for people that, suffering from lupus and they're listening, or they know someone that is? How do they start finding out more about the condition and finding different treatment options?
There are a lot of wonderful resources just through nonprofit organizations that fund either lupus research or different patient initiatives. I don't necessarily want to preferentially list one or the other, but I do know that there are a lot of good organizations that are nonprofit organizations that do a great job communicating that information to patients. And then obviously, if there is somebody with an autoimmune diagnosis, your rheumatologist is going to be a great resource too.
Okay. Well, very good. Very good, Nicholas. Thank you so much for coming on the podcast and talking about this. I appreciate it.
Yeah, no problem. Thank you so much.
Thank you for listening to the Good Question Podcast. Please email support@thegoodquestionpodcast.com if you have any referrals to great guests for us to interview. Visit thegoodquestionpodcast.com to hear more interviews. And please help us spread the word by rating and reviewing us on Apple Podcasts, iTunes, Spotify, YouTube, or wherever you listen to this podcast.